Good evening, everyone. I'm glad you've chosen to spend some time on this hot day with me. I'm Jordan Scheff. I'm the commissioner at DDS, and I'm going to get to some housekeeping in a minute, but I wanted to set the stage for why I'm here tonight doing this, and hopefully why you're here listening to me. As I've shared in some writings that have been shared with some families and staff, towards the end of our legislative session, there was a historic wage bill pushed through the legislature that really begins to address the workforce crisis in our private provider community. And all total, that was will approach $185 million or so of money invested in the system. And while I was related to the negotiations, excited about the fact that we would be avoiding a strike and that we would be investing this kind of money in the provider community, it was challenging for me because I know that they're just one stakeholder at the table, an important one. Without our providers, we don't have a lot of services to offer. So it was essential to stabilize the workforce. But with that kind of investment, I was concerned that other stakeholders, people who don't have all the services they need, or some people who don't have any services they need, wouldn't see that their needs were addressed. It's also the first time in a long time that we've been able to look at that type of investment. And so I thought it was an opportunity for me now to present some information to a whole bunch of groups of people, families, providers, advocates, our own staff, and sort of set the stage to try and help people see what I think I saw during that moment where I wanted to make sure that with this investment, we did our best to leave no one behind. And so I'm going to present some information tonight about that, and then we'll talk about next steps. Moving to the next slide. Those of you who know me know that I would much rather be having a conversation with you in the hallway at the LOB, at your child's day program, in my office, on the phone, or in small groups that I've facilitated over the last few years where we can have face-to-face discussions. We're going to have those coming up soon. That will either be face-to-face or virtual, but smaller groups, and my staff will help me facilitate those. We want to have many of those coming up. But for tonight, you're stuck with me talking at you in more of a presentation style. But there are opportunities for you to participate, if not tonight, in an ongoing fashion. So if I remark on things today that create a question in your head, in the email you received earlier today, or perhaps yesterday, and again, a reminder today, there's a form link that says have a question. And you should feel free to click on that and submit your question, and staff will help me potentially review some of those at the end of my presentation a little bit later on. In addition, following the presentation today, you're going to get another email asking for your feedback or additional questions, and that will be a different form, and we'll put all those together. In the end, if we don't answer your question while I'm presenting tonight, you'll have an opportunity later to receive additional notes we'll post to the website. We'll consolidate the most frequently asked questions. We'll try and address as many as we can, and perhaps provide feedback to you later on down the line in some other form. So this presentation will be recorded. Parts of it may be shared on the DDS website for people who are unable to attend. We'll take the best and the worst of what I have to present and edit some things together. So people who couldn't participate tonight can still participate in the future groups that we look to have and find out what they missed. We're excited to do this. It's a little bit different. And in the end, in addition to the sort of epiphany I had, information we get from those feedback sessions will help inform DDS's 5-year plan that we'll be working on. So moving to the next slide. I thought it would be helpful to address some of those things that I said led me to wanting to do these conversations. So the first thing you should note, just to give you an idea of things going on, it was a fruitful and busy legislative session for us, as it seems to always be. And we are very happy that our agency bills that we asked the governor to sponsor was approved. And just some of the things that we're including in that are mostly technical in nature, but our abuse and neglect registry had been housed here and continues to be housed here. Because DAS is now involved in the hiring process, we amended the statute, the language, so that they could have access to reviewing the abuse and neglect registry as well. We expanded the emergency medical authorizations that the commissioner, myself, can grant. We use those very, very rarely, but it was outdated in that it was specific to surgery. It's now includes certain procedures, things that were done surgically in the 70s that can be done by procedure now. In an emergency situation, I can provide consent where we're not able to reach the next of kin in a timely fashion. And some minor changes to the probate court statutes around our redeterminations and the eligibility process and how those are conducted. But outside of the technical bill is additional things that were done. So the legislature passed a $2.7 million bonding package. Those bonds will cover a number of things, but most notably for DDS, there's $500,000 for infrastructure repairs out at Camp Harkness. For those of you who benefited from access to the camp over the years, there are some ADA things, some accessibility issues we wish to address, and then just replacing some things that are under duress due to wear and tear, like child swing set and some other things. But there's to work with the marshlands and all that, there was a significant amount of money needed to increase the accessibility in the cabins as well. An additional $500,000 for renovations and for consolidated, closed, or converted group homes, and another $750,000 for emergency and minor capital improvements. The big ticket item is that in the big budget, not the bonding budget, but the operating budget, is that we were mostly held harmless. For those of you who've been visiting with me over a number of years, we suffered a number of years of cuts and setbacks. This largely kept most accounts whole, in addition to infusing that nearly $185 million over the biennium into wages. So we're very happy and excited about that. And that was part of what we were excited, part of what led me to wanting to have this conversation. But the other impetus here, besides the wage package, is a not insignificant bill that was passed. It's one providers and advocates have been talking about with the legislature for years, and the current administration was amenable to it. And that is the removal of something we refer to as cost settlement. What is cost settlement? In prior years, in this year, in fact, too, when agencies are given money to provide services and don't necessarily use it all, many years ago, they used to cost settle at 50 cents on the dollar, meaning the state would take back 50 cents for every dollar that they was left unspent if they were efficient in the way that they operated. Now, they had to provide the services, they had to provide the outcomes, but it allowed them to set aside some money for when they had less than great days and could get ahead on some of those other things. For a period of time, even though it existed in statute, it was subject to the secretary approval or a denial, and 0% cost settlement had been the process for a number of years, meaning there was no incentive, there was nothing in it for providers to really be efficient because they were left having to return the money to the state. And so we saw that tended to be the case, and it stymies creativity, it stymies efficiency and an interest in doing so. So I'm planting these seeds. This little tour of mine this summer is the Seeds of Change tour. And so I want you to hold on to some of the things I just covered here, because while they may seem benign, it fits in the larger picture of why you're visiting with me tonight. So let me give you a lay of the land. DDS in total, as of June 2021, has eligible for the department just over 17,000 people, 17,229 as of June 2021. And of those people, this is how people are supported or interact with us. You can see in the chart in front of you, there are several pie pieces. The largest pie piece there is individuals who receive both residential and day support, meaning that they have annualized funding for both their residential needs or their day needs. And in a future slide, we'll talk about what that residential side looks like. What are the major components of the residential side? Beyond that 40%, we have 23% who get day support only. Pardon me. We have 6% of the people who don't have a day program and just get residential supports. And then about 31%, or just less than a third, of the individuals we support get support and services potentially through the helpline. To give families an indication, what does helpline offer? It provides some support connecting to community resources. It facilitates the family grant program. It can connect families to other resources, including our camps and other things. And our helpline workers across the state are really dedicated and do their best. But we have a fair number of people who they support. But that gives you an idea from what we call the Management Information Report, the MIR, which is available on our website. So I'm sharing this data with you now. If you're ever curious to go back and look at it, there's a link to the Management Information Report on our website, and there's all sorts of interesting and good data there. I mentioned we've talked about the residential types of residential settings. And so here's just a brief list of them. We'll move into a little more detail in a minute. Fundamentally, these are the 5 major programs that we offer. I say that, couch that carefully. Some of these things can be offered within other divisions like self-determination, but the basic living models we rely on often are what we call continuous residential supports, or CRSs. CRS is capped at 3 people. It's not technically a group home as it's not licensed. It has strengths and weaknesses. They can be stood up very quickly. They can facilitate families wanting to do their own planning for how their loved one or individual may live. But they have some downsides too, in terms of a lot of people who live in them feel at times financially strapped. You're still working with an agency, and so the staff supports are contingent upon their abilities. But we have around 450 of those statewide. The next line down talks about non-ICF CLAs. That's government speak for group homes, intermediate care facility, community living arrangements. Non-intermediate care facility, community living arrangements. Those are our group homes. There's about 850 across the state. I think it's, when people think of DDS and residential supports, I think it's the model they think of first if they're not familiar with what we do and how we do it. And it's certainly the model we moved to during the days of deinstitutionalization. We're going to talk a little bit more about that. Independent living are individuals who live in their house, in their home, in their apartment, wherever they may be living, and we provide intermittent in-home supports. And we also do that in family homes. So we list that separately. So who's living on their own, who's living with family, with annualized paid supports, and then community companion homes. If you think of those more of a host home, if you're not familiar with a community companion home, an individual, a licensee, can open up their home to share with an individual with intellectual and developmental disability, and we provide a stipend in trade for that opening of the home, and we provide technical support and case management and other things. So I just wanted to define those for you really quickly. The couple of things that are not listed there that we will start, that you can find in the MIR, or we'll be able to find in the MIR in the next quarters, the Management Information Report. Shared living is a model that we would like to consider further. It is similar to community companion homes, except that the home itself is that of the person receiving supports. So when the relationship between the provider and the individual ends, it isn't incumbent upon the individual being supported to have to move. What we call mixed-use housing projects, the best known of those is what we used to call IDASH in our budget. And that's a home, our first example of that is a home that opened up in Farmington Valley. And that is a project and a product that caps the number of people with intellectual and developmental disabilities getting supports in a living development at 25%, meaning 75% of the people living in the same apartment complex or housing structure are not receiving supports from DDS. We have 4 or 5 more of those coming online now over the next year and a half, and we hope to have even more of those going forward. But it's such a small sliver of the pie, I didn't want to use it in the next slide that I'm about to show you. And the last of those is self-determination, which is a model of supports and services where the individual or the family gets to hire and arrange their staffing as they see fit based on their needs and the money that we authorize in their budget. So what does that look like in terms of utility? How do we use those services across the state? And it's important for me to share this stuff. I am building towards what I hope will help you arrive kind of where I arrived at. But if you look at the chart labeled percentage of people in residential settings, you can see that the two things that most look like group homes in that chart are CRSs at the top and the non-ICF CLAs. That's 55% of people in getting residential supports live in those types of settings. The balance live in the independent living, in family homes, or in community companion homes. When you look to the right of that, you can see the percentage of budget used in that graph, and you don't have to do the math through all of that, but you can see that 55, if you take a look at the left, 55% of services costs us 82% of our resources. All right, we'll say that again real quick. 55% of those receiving supports costs 82% of what we're appropriated every year. Okay, so hold on to that little nugget for a little while because we're going to come back to it. But here's another way to look at that. If you move to the next slide, Joe, you'll see in these two charts, okay, the left side shows where people are living, with the top part being individuals living in CLAs, that middle part before it switches to black being people who live in CRSs, and then the rest being in all those other settings. And then you move to the dollar sign chart next to that. Okay, so you get an idea that the dollar signs that match the colors are going to the people in those settings. Okay, and that's I'm just trying to reinforce that disproportionate cost of care versus the number of people being supported. What I'm telling you is that these are our most expensive models of support. They're necessary models of support. I don't want anyone to leave a presentation tonight saying the commissioner said we're shutting down group homes or we can't have group homes anymore. No one going forward is having group homes. That's not what I'm saying at all. We're going to talk a little bit more about what I'm saying, but I don't want anyone to have a reaction to the fact that I'm showing the disproportionate costs over the amount of services being provided. And so I share that with you as well. And I think it's important to know the cost per person by setting. So if we move to the next slide, you'll see that this reinforces again the costs. Those first two columns are CRSs and our CLAs, our group homes and our three-person group homes. The average cost per person supported in there is CRSs are a little bit higher than the group homes at present, and there's a couple of historic reasons for that. And then you'll see the costs per person in those other settings, in independent living, in family homes, and in CCHs. So let me talk just a little bit about why is community continuous residential supports more than group homes? Well, there's a couple reasons. One, we are often left, because of the length of time it takes to develop a group home, to utilize that continuous residential supports model for people in crisis. It's not ideal, but it's faster. Often people in crisis are in crisis for a reason, and their costs can be generally higher. Some of those people in crisis who are getting placed in those settings may have behavioral or medical challenges, or what we call forensics challenges. And so their cost per person may be a little higher, or it may be that because they are a higher lawn and could no longer wait on the wait list, and we made the decision to make them an emergency, they came in at a higher dollar cost. The group homes, on the other hand, have some historic placements in them. So people who years ago were placed who may not have a particularly high lawn, but are receiving those supports in that setting because that's where they were originally placed and that's where they live and that is their home. So you can see the cost there. I think that gives a pretty good description gives you an idea of what those costs are. And the costs for some of the other settings I talked about earlier, the I-dash housing or the mixed-use housing, are also lower than our CRSs and our CLAs. Oh, and I should mention another reason CRSs are often cost more is because the cost of the overnight assumed in that model is spread out over 3 people, whereas in group homes we can have as many as 6 or more living in a licensed group home, and so the cost for the overnight is split across more people and drives the per person costs down. But enough about costs for now. We're going to move on and talk a little bit more about people who live there. So I've talked about these other models of supports, the in-home supports, supportive housing, CCH, self-determination. I mentioned the mixed-use housing. We also have clustered supported living and other smaller one-off type models. So what do we know about those programs? Is we know that they are highly integrated programs. They rely on not just staff supports, but community supports, connections to natural resources. And we know that they are able better to integrate into the community often. I say that there are group homes who do that as well, and community continuous residential supports that do that well as well. But I can tell you from family feedback, from provider feedback, from our quality assurance unit, that the level of integration is often higher the more independent the setting is. And we know that people can be more independent living in those settings. They have more control and autonomy over choices they make. They're sharing the house with less people. They're sharing their living environment with less people. So, you know, if they're living alone or with a roommate, they're sharing the remote to the TV with 1 or 2 other people. They're sharing the menu options for the week with a smaller number of people. Sometimes they make those decisions alone and they live alone. Sometimes they're doing that with their CCH provider or with a family member. But there's more independence available in those settings, just the nature of how they are. We often refer to those that opportunity as there's a value-based decision that one makes as to the level of independence versus the level of staffing or the level of need. And we find that these settings are lower costs to maintain when they're rented from a landlord. The repairs to the home are often incumbent upon the landlord. The homeowner is, if they're a licensee and a CCH, and they're lower costs to staff because there's not a presumption that there needs to be 24-hour staffing available on site at all times. So we're going to talk just a little bit more about what that means in terms of the levels of need of people living in different settings. So one of the things that I think is a bit of a myth is that people living in group homes are living at very high lawn levels and people living in other settings are not. And what you can see from the data chart here is the average lawn by setting type. So the average level of need, if we were in person, I'd have you throw stuff at me for using acronyms I'm not supposed to be using. The lawn is the level of need score and this is based on settings. So we know that there's an average lawn of 5 3/4 in our continuous residential supports. There's an average lawn of 5.89. Those are very close in our CLAs. In independent living, though, the average lawn is 5.25. It is not drastically different. And the average lawn in our CCH is 4.71. Where we do see a bit of a discrepancy is those people still remaining at home have an average lawn that is much lower. That doesn't mean that they don't have needs, and that doesn't mean that the families are not looking out for their loved one or that they have it easy. It just means that the lawn is lower and we're able to meet their needs in the family home, and that's what the average is. So we're continuing to build a story about what is it that made me think this was the time to have this conversation. So I'm going to continue to plant a few more seeds, and we're going to move on to the next slide. So what does this all mean? So one of the things I think is incumbent upon us now is to ensuring that the correct level of care is being utilized for individuals we support. Are there people who are overserved, meaning they get more resources, more staff, more dollars than is necessary to meet their needs? Or are they underserved? And we know that we have a number of underserved people and some people who are not placed in the right setting that need to be in a different place. But we have a system that's pretty well saturated and a lot of people waiting for services just in general. The theory that around providing supports and services that I've embraced for over 30 years is a phrase we use in the industry about the most effective and least restrictive environment for people. Now, in the land of steady habits, when I say that, I want to be really clear that we're not talking about putting people at risk for the sake of moving people around. But we're talking about, are they getting the most independent, go back to that other slide about what is important about those settings. Are they getting, one more behind that, Joe, and then go back again. Are they getting community integration? Are they getting more independence? And for the state and for those, the collective, all of us, families getting services and families not. You can go back again, Joe. Are they getting the most effective and least restrictive services they can, so that in the end, we can serve more people with the dollars we get? Can we provide the right services at the right time, and so that more people can benefit? One of the things that's interesting in that middle, in the picture of the house in the middle is, and we're going to talk more about pandemic issues a little later on, but what we know is that it's a difference of person-centeredness versus system-centeredness, and that the more comprehensive the system, the more the system produces the outcomes and the structures. The smaller the setting, the less restrictive the setting, the more the person has control. During COVID, we took a very system-centered approach. It grated on me the whole time that we weren't able to make person-centered decisions the way I've always tried to embrace that. But it becomes the complication of living in larger congregate settings and sharing houses with other people, that you're in a complex situation in terms of balancing individual rights with the rights and needs of everyone living in the house. And we're going to talk a little bit more about that. But I also want to talk a little bit about how DDS has supported and enforced some of the barriers I'm going to try and discuss eliminating in that. And this is true not just Connecticut Department of Developmental Services. Recently, I've been training in the Charting the Life course materials many of you have become familiar with through the IP. And what we know is that people inside the system and people familiar with the system always point to what they know about the system as the solution. It's just inherent in what we do. So that when we built the system, the community-based system that we built in the late 80s and 90s, we built group homes, branched out into apartment programs. And that's what we keep coming back and looking to. And very often when there's a family in need, the right level of care at that time is a comprehensive service. We may not know a lot about the person. The home may have been destabilized prior to them coming to us. The individual may be destabilized. And so we point to those comprehensive types of care, the CRSs, continuous residential supports, in the group homes. But that isn't always the right way to serve someone long-term. But we don't have a real good process of reevaluating whether someone's placed appropriately. And we don't have a lot of interest, or as I mentioned earlier, there's not a lot of incentive in the system for providers to consider doing things differently, or for families for that matter. So I think as we go forward, we need to look at what we know about those settings, how we serve people. And we don't need to, we don't want to evaluate things based on risk, but we need to make value-based decisions. We need to be engaged as to what the trade-offs are, where there's more quality, where there's more independence, where there's more rights and autonomy, and what that means not just for the individual, but the other people in the system as well. So we'll come back to more of that in just a couple minutes. We're going to move on, though, to the next slide and talk about the current wait list. I mentioned at the start of this conversation that it was challenging for me during the pandemic to watch the wait list grow a little bit. We had some success at seeing those numbers shrink, even without articulated funding for wait list. But those numbers have creeped up a little bit. I think some of the reasons for that are pretty obvious, but they've come down even without the pandemic officially being over. At one point, that emergency list, which is 40 people with no services and 30 people underserved, was over 100 at its peak. I think closer to 120 or 130. So our work now, with things reopened and it easier to place people being vaccinated, staff to some degree being vaccinated, we've been able to go back to through the process of placing people. We have a few more people on the urgent list than we did, say, 2 years ago, but that number's come down a little bit as well. And we have the future needs. For those of you not familiar with the waiting list, we look at these 3 categories. Emergency as being imminent, immediate, as quickly as we can get people safely placed. We look at urgent as being within a year or so, how we're trying to place people, and we look at future needs as more than a year. Though that number statically around 2,000 is pretty close to where we stand now. Could be a little lower, could be a little higher. But I think it's important to note that, as I was having this moment, $185 million being invested in the system, these are the people that I couldn't not think about, that weren't going to have needs met that night through the additional funding, at least not immediately. So what was in it for them really became what we wanted to talk about. So I've indicated to you so far that we have information about who lives where, about the costs associated with that, the fact that we have people at different lawn levels living in different settings successfully, some people at our highest lawns living in the most independent settings. And I'm going to give you some examples of that in a moment, I believe, because the system isn't always what we need to be pointing to. We really need to be looking at individual needs. And sometimes you can support a person even with complex needs in a less than comprehensive setting. And we can talk about some of that and some of why we think we can do that and better now than ever before. So before I start to bring these dots back together, I want to talk a little bit about the lessons learned from the pandemic. Some of you may remember my attempts to push the use of assistive technology and the utilization of technology in general a couple of years ago, and there was not a warm embrace for my push on that, and I'm okay. It takes a long time to push through change, and I'll continue to try and do that. But it was during the pandemic where people who had originally said, no, technology is not going to work for my loved one, and I'm not interested in hearing a whole lot about it, were suddenly very reliant and willing to use technology in all sorts of ways. It allowed us to do some remote monitoring in licensed settings. It allowed us to allow families to have FaceTime opportunities. Some individuals benefited from remote day programs when there wasn't other program and structure. It allowed them to see friends at a time where none of us could see friends if we were following the COVID restrictions. And while that doesn't work for every individual with intellectual disability, I think we learned that it worked for a lot more people than we had interest in prior to the pandemic. It worked so well, in fact, that some people want to continue to use that technology instead of returning to the traditional service modalities that they were in. And so we can talk a little bit about that. It pushed me into increasing the communication I had with staff and through staff with families and providers, but less about me and more about other staff and about the providers. Was just that open and ongoing timely communication was important. We were largely successful through the pandemic in many ways, and that was due to ongoing and timely communication. And even when we couldn't tell families exactly what they wanted to hear, just knowing they could get an answer from us, even if it wasn't they wanted to hear, at least we were able to get back to them. We learned that densely congregated settings in this situation led to isolation, and that is true of both day programs and residential programs. People who were utilizing densely populated, congregated day programs were prohibited from returning for a longer time, and still many have not been able to return for a variety of reasons, mostly because those programs don't afford the space people need. It's also harder to move to very individualized programs when you have a lot of people attending a program together. And in the group homes, while they were in relationship with one another, the housemates, not all housemates get along, and many of you know that. In my own house, we don't always get along, and they're not always the people I want to be spending each and every day with. And if you don't get along with your housemates and you're cut off from family and the community, it becomes very isolating. Even if you do get along with them, it gets old fast. And because of the nature of the way densely congregated settings, whether it was nursing homes, group homes, institutional settings, were impacted by the pandemic. We know that people suffered trauma from this type of isolation, and we learned it wasn't good. And what we know now is people who live in more independent settings have re-entered community and relationship and left isolation sooner than those living in larger congregate settings because of the risks to others unrelated to them that they live with. It's been very hard. It's been very hard on people we support. It's been very hard on families. It's been very hard on staff. This was not easy on anyone, but I think that we know now, looking forward, that perhaps the types of settings we've relied on, while they provide some benefit, also come with some downside. Visitation disruption was enormous. I think the number one concern for many families, many individuals we support, is that visitation got disrupted. Even when an individual was vaccinated or had already had COVID and recovered, families weren't allowed in because there were other people in the house who we were not able to share that about. There were staff who could be impacted. And again, part of that's around the congregated settings, part of that's around the way people live their lives and how we do that. And I mentioned this next part earlier, system-centered decisions versus person-centered decisions, especially related to health and safety. So we learned that we were forced to make those system-centered decisions, and that while they effectively largely kept people healthy and safe, they were not popular, and it didn't leave room for exceptions. And we had to do that. It isn't anything I ever thought I'd be doing in all my years, and I hope I never have to respond that way again. But we learned that there's some upside to system-centered decisions, but that they really take away from person-centered outcomes and a person-centered decision process. So with all that, I'm going to skip down, Joe, to, well, hold on one second. Okay, I'm going to move right into 14. So let's talk a little bit about ARPA funding. ARPA, another acronym I promised not to use today, the America Recovery Plan Act funding. There's additional opportunities. So as I'm thinking about looking forward to the future, and even when I wrote the letter about the fact that we would need to go through this exercise, I knew that we would be getting additional money through ARPA, even if it wasn't public yet. And that funding specifically will go to expansion of respite services. So those of you who've been around a while remember when we used to offer 6-day weeks. We'll be able to do more of that with this additional funding. There's specifically some funding that will go to other agencies besides us from the $3 million appropriated. Aging and Disability Services will get some for their senior support programs, and DSS will have some for the autism, people who are eligible for the autism waiver, who are over there being supported by DSS. There are strategic investments in behavioral health, largely because of the trauma caused by the isolation in the pandemic. There's money that will go to creating, and I'm not going to do a good job selling this one right now because it's too much in its infancy, but what we would call a health and human services one-stop. Any of you on the phone today who are engaged in business with the state may know about the upgrades to the state website for businesses in a business one-stop. myct.gov will at some point going forward have a health and human services one-stop. What does that mean to you? It means instead of needing to figure out what you're doing over at DDS and DSS and DCF and maybe DMIS or wherever other places, elderly affairs, aging and disability services, early intervention, you'll have a single login to a website, and the activities you most typically engage in will have a dashboard there for you. So if doing your eligibility, your Medicaid eligibility redetermination is one of those things you do every year, you'll log in, there'll be a button to click to engage in that process. If you do requests for family grants on an annual basis, there'll be a button there for that. We'll build that up so that it's customized based on your experience and what you need. And the idea is that government would become somewhat seamless. And those of you who have had the experience, and my guess is most of you have, that get tossed back and forth between agencies. Oh no, try over here. Oh no, try over there. Oh, that's not my job. Oh, that's not my job. This should eliminate some of that. It should be ease of use. And it's a strategic investment the state is looking to make. And there's additional money coming in to support the recovery of private providers from the pandemic so that we can ensure that they're stabilized We can reward them for the heroic efforts they've made to keep people happy, healthy, and safe, and attract people back into that profession where we have a huge workforce shortage. And that's not the end of it. In addition to the ARPA funding, there's a FMAP, and I'm not going to be able to do a good job of telling you. That's with a financial match. I don't know what the A and P are for. But the feds determine state by state traditionally what the reimbursement would be for Medicaid funding. And for most things in Connecticut, it's at or about 50%. MFP reimburses a little bit higher. But what the feds did is they took a look at a window of time, roughly a year, the most adverse 12 months of the pandemic, and they told states who do home and community-based services, HCBS services, you have access to an additional 10% FMAP bump. And so we've submitted a plan that brings additional resources into the community, again, fueling my thoughts that we have a time to look at efficiencies, we have time to look at the system, we have time to look at options and opportunities, and how will this money be invested within our community? Well, technology resources, not just assistive technology that we'll talk about later, but how, like the One Stop, but other ways that technology resources can be helpful, facilitating your engagement with us, those we support. We're looking at modernizing and transforming systems, so technology. We still rely on a paper annual plan through case management and lots of paper forms. We're looking at an investment that would update and modernize our case management system, move us away from paper, copy, file, and fax to something completely electronic. We would look to apply some of those same principles to the NCI, the National Core Indicator Project, which is part of our waiver assurances. And we have an opportunity to broaden the continuum of supports. So we're looking for more money for that supportive housing model, the clustered supportive housing models. We're looking to see if there's additional respite, and we can talk more when we have these community conversations with you about other holes you see in our continuum of supports that we could look to address with these large infusions of money. It's not yet approved by Center for Medicaid and Medicare Services, but we took a look at plans from all 50 states that were submitted, and a lot of what we've included, they've included, and so we're optimistic that we would be able to get some of this access to some of this broadening continuous supports money. I also think there's an opportunity to incentivize system change, to increase opportunities to those on the wait list. So what have been some of the barriers to change previously? If the magic was within the system, what are some of the barriers to change? Well, I talked previously about an unstable workforce, an unstable provider network due to low wages. The state addressed that on its own and will continue to address that. What were some of the other barriers? That we look at the system for the answers, and when the system says group homes and CRSs are always the answer, we continue to spend money in a way that may not be the most effective, most efficient. We may be overspending at times, we may be under-resourcing at times. But we also talked about the cost settlement piece of that just passed this year, that providers can't ever get ahead and there's nothing in it for them if they are to perform efficiently. This would allow us not just beyond the cost settlement, but to incentivize the system further. And we'll talk about, I hope we can engage in that conversation with the providers we'll be meeting with staff and with you about how that incentivization might look. But there's some agencies who've engaged in this without incentives that have done some extraordinary things, reconfiguring the way people live, not to them, with them, right? Nothing about us without us, as the self-advocates would say. They work with people within their system to consider other options, and they were initially denied an opportunity to retain the savings that they wanted to reinvest in supporting more people. In the way that we're looking to incentivize the system, offering that opportunity to providers to reconfigure and work with their families and those supported that might, within the same authorization, bring a person or two off the wait list. We would look to reward those efforts and provide an incentive to the providers for engaging you in that process. But even more than that, could we create part of the barriers that people are reluctant to consider changing how they get their services because they're afraid there's no placeholder. If it doesn't work, can I go back? When my kids went off to college, they wanted to know, if I don't like college or if I don't fit in, can I move home? And I was able to tell them yes. We haven't been able to make that promise to our private providers or to families that if they leave, they could come back. And partly because if they leave, we have no way to pay them. Enhancing, incentivizing the system and looking at that may allow us to hold a bed for a number of days or a support structure for a longer period of time, so that if someone didn't love the new living opportunity we help them arrive at, there's an opportunity. One, the provider's held harmless, they're kept whole, and the bed can remain available if in fact we need to take one step back after taking two steps forward. Additional FMAP funding would go towards enhancing quality systems, how we do quality and how that rolls up, promote and facilitate the use of assistive technology, including staff to help us identify where solutions might be helpful in creating efficiencies within the system, in creating independence within the system, and creating a higher level of satisfaction with service delivery. And then we also asked for additional money for people who are self-directing. Both DSS and DDS asked the feds for additional funding, what I'm calling an employment network for self-directed services. So that one of the things we learned during the pandemic is it was very hard to arrange for self-hire staff, and it was very hard to recruit. And that when you're self-directing your supports and someone can't show up for work for one day, it's one thing, but if they're out for 10 days, that's really, really hard. So what we're looking to do is develop a network beyond what rewarding work, another website that we use to do this, to allow families to identify staff who have necessary training and availability to work, to do it geographically, and to build a networking system to share staff and resources, but also to find them when you need them. Lastly, on this slide, an additional opportunity I believe will come down the pike during the current federal administration is a long overdue expansion of home and community-based services. There's a lot of speculation about what that would look like, but we believe that there'll be additional money added to the system in time to help us address things like workforce crisis and the waitlist issues that we face here in the state. So one more ingredient to go through before I wrap up is part of our network of services that most of you have not had access to and likely won't have access to going forward, and that's our public services. So public, currently, let me just describe what they do today, and then I'll talk about what they might look like during a period of transition while we sow these seeds I keep talking about. Community living arrangements, there's about 30 to 35 of those that public continues to operate. They support some pretty complex people medically in those homes and some behaviorally. We still have our 3 regional centers, the Northwest Center in Torrington, the Lower Fairfield Center in Lower Fairfield, and the Hartford Regional Center in Newington. We still operate Southbury Training School, may be able to save a question. We're at about 142 people in the census at Southbury Training School today. And we have some very specialized programs that we've stood up in the last few years. One of them is not that new, but the others are. And part of that has been because of the workforce crisis, because of the wage and funding crisis in the private provider community. It has been hard to do some of our more complex work in the private sector in a timely fashion. So we have a transitional unit which helps people transition from a life of incarceration to a life in the community, sort of a halfway house, but it's limited to 4 people at a time. We have a step-down unit that we've talked about quite a bit. I'm glad we stood it up before the pandemic. The step-down unit helps people who are in emergency rooms around the state with complex mental health issues, in addition to intellectual disability, transition out of a hospital bed to our step-down unit facility located in Newington, and within 6 months of being there, being placed in a private provider integrated community program. Also, like as I mentioned, we have an availability of resources that our private sector doesn't. that we can do some medically complicated care. It is done in the private sector, but the workforce crisis extends beyond direct care to nursing, and it is tough for them to recruit in a timely way to build up a medical care model. And so we use some of our specialized programs. We've done this for people who were entering late stage of life and needed a compassionate way to spend their days towards the end, but with medical oversight, as opposed to asking them to go to a nursing home, things like that. Or someone recovering from surgery who needs 24-hour nursing for a period of time. And we have other transitional housing we use for some people in crisis. So that's what they do currently. That's what they're doing today in public. Over a period of transition, while we look at these reinvestments in the private provider community, public has an opportunity to continue to serve those current roles, continued operations of their existing programs, but they will see additional capacity as our public programs have, because we don't routinely admit people to them. So as people either move out of public settings or pass on, we'll have additional capacity there. And we wish to use that currently as we pivot to other investments in the private provider community for these hard to support catchments, those catchments I was just talking about, people who are very behaviorally complex, medically complex, otherwise difficult to place, facing forensics issues, not for long term, but so that private providers can partner with us to build up the infrastructure they need to safely and adequately support those people in the community. And then we'll talk a little bit about the next slide in terms of what the future holds. I do believe that going forward, we think that public serves a valuable role in these step-down units. Despite having a 6-bed facility in Newington, I know there's still people in hospitals that could benefit from another place to live, because the hospital's no place to live. And we could help them step down from the hospital to community settings, the medically modeled homes where we can take people with complex needs because of our nursing oversight that isn't necessarily readily available in the community, and those transitional supports for a future state. So if we're helping to move people into the next stages of things, that we could use public as a transitional setting while we're building other capacity within the system. Joe, don't move on to the next one yet. I missed an opportunity for a comment I wished to share earlier, and it was back about the meeting people in the right place. Just because you have a high level of need doesn't mean you need to have a high cost program. And so I'm going to talk about one particular example. I could talk about many, but I only have a few more minutes left in the time I was planning to take before we move to questions. So I'm going to tell you the story of a continuous residential support program that was operated in the North region. I was there. I'll leave out the names of the providers and the staff who assisted me with doing this. But we had 2 individuals, happened to be 2 women in this case, with very complex mental health needs and on top of their intellectual disability. The system, when those individuals needed placement, looked inside the system, because that's what we all do, myself included. This isn't a blame game for me. And we pointed to what would work best. And because we could stand it up quickly, we had 2 separate women in crisis. We could rent a house for them. We could have them live there. It would feel, in terms of comprehensive supports, like a group home might feel. And so we staffed it, and we opened it with 2 women there. There were 2 staff on during waking hours and 1 overnight. When things didn't go well for both of those women, each of them taking turns having days that weren't their best days, we responded the way the system does. We bought more staff. So we went to having 2 staff on during waking hours and 1 staff during the overnight, to having 3 staff on during waking hours and 2 staff, first 1 staff, then 2 staff overnight. So now I have a program that, with that kind of staffing complement in the right places, could support 3, 4, 5, 6 or more people, depending on the individuals, now supporting 2 and not supporting them well. They were still in crisis, and our response to that crisis is add more staff. Well, when we continuing to add staff was no longer viable for me as the regional director, we decided we were going to have to try some things based on some value-based decisions. And based on what we knew about those ladies, what they wanted was some autonomy. They wanted to self-govern themselves. They wanted some of the nice things their peers had, like peers without disabilities that they knew that they had, and they wanted control in their lives. And so we took the chance and we rented an apartment for one of those two individuals, later both of them. There were some trust issues early on, but that person who couldn't survive in the community with two staff assigned to her by three staff assigned to them by day and two by night, we rented an apartment. We overcame the trust issue she had with staff. It was rented for a little while before she would actually stay in it. She had taken off and was on the run. And as she came to realize that it was her apartment, she started to spend more time by day there and later by night. And later on, she was quite successful in working with us. She would refuse day program initially, but she added a day program back into her life. She worked with us to make sure she could officially have her boyfriend move in with her. And we provided supports to her on a sliding scale based on when she needed them. When things were right for her, when she wasn't decompensated, she didn't need a lot of staff. She needed help with shopping, with banking, some job coaching. When things were really bad, she needed help keeping herself and the community safe, and we could ramp up staff. That's the kind of thing I'm talking about that leads me to believe we have this opportunity now. Because if what we always do is point back towards the system, if what we always say is the answer to problems is more staff, more staff, more staff, while we'll do a decent job of supporting the people in services, we're going to have a system that continues to need infusion of cash to support workers in the provider community, and we'll continue to have a wait list. And we'll continue to have people with unmet needs living in their family homes, even if they have some annualized supports. I believe somewhere in all of this, in all of these points that I've mentioned to you tonight, that together as a community, we can come together. We can talk about what's working and not working. We can talk about gaps in the system, and we can talk about opportunities to leverage these really once in a lifetime opportunities: reduction of cost settlement, ARPA funding, FMAP funding, the wage infusion. The fact that we have technology coming online, we have federal support coming online. If there isn't a time, if now isn't the time, I don't know when is. And I don't know that taking my commissioner hat, putting my advocacy hat on, I don't know that we can ever have enough advocacy to go back and look at that wait list and say, we need group homes for all of those 2,000 people. I don't think we'll ever get to a point. I don't want to be a state. I don't want to be a commissioner that operates with the wait list, and I don't want to be reliant on that legacy system to move us forward. I think we have an opportunity to do that now. And so what are the next steps for this? The next steps, you will be getting email, as a reminder, you get an email after this for additional questions. There will be an opportunity. Joe, move past public view. Oh, I'm sorry, that's me. You're good, Joe. Joe's helping me do the slide deck so I don't get distracted the way you've seen me get by all sorts of other things that fly by me. We'll have regional community conversations. More information will be coming out how you can participate in actual discussion and not just listen to this guy ramble. So be on the lookout for invitations to those. They'll be held around the state, and we'll have central office representation, if not myself, and one of my staff, as well as regional staff who may know you better or know the needs better. Feedbacks and questions, don't forget, we had a link you could use during the meeting for some live questions, which we will see if we're going to move to. But there's I'd love feedback on the process, how we're facilitating this this lecture. It's not a conversation tonight. But also, if you have any additional questions that come up afterwards, you'll get an email once we close this today, and you can do follow-up then. And we're going to synthesize all of this for you and for us. There'll be frequently asked questions that we'll post to the website. We'll incorporate what we feel are the best opportunities and ideas into our 5-year plan, and we'll continue these dialogues. I try to get in a cycle of visiting with families without a specific agenda. I think that for me, we need to continue to have these conversations in repetition, and people will move in and out of them. But I think in order for that to happen, we need to just get started on this schedule and get used to having them and work together to try and find some solutions. So I'm being handed a short list of questions. and I'll try and walk through some of those in the time we have remaining. And before I forget, for those of you who may not stick around for questions, thank you for listening in tonight. Hotter than heck out there today, a lot of things going on. It's the middle of your summer, and a lot of you took time to listen to the ramblings of this commissioner post-pandemic and post-budget cycle, and I really appreciate that you take the time to do that. And I hope if you found it helpful, people who couldn't make it tonight, you might suggest to them that it may be worth watching just to get up to speed prior to these community conversations. So some specific questions. When will respite centers reopen? So some respite centers began reopening in the last couple weeks. If you haven't been notified about opportunities or been told when your respite weekend is, you can reach out to your case manager helpline or the respite staff. I will caution you that we had a power outage at 1 this weekend with the fact that we now live in the stormiest of times, and we had to have some individuals leave, go home to their families because the generator didn't support all the needs of the individuals in the house, particularly the entertainment stuff that folks were looking at. And then we did have some staff who we had found had been exposed to COVID. They were removed from those settings. We notified all the families there, but it was a small outbreak through some individuals who are vaccinated, and it seems to be pretty well locked down. But depending on what we do with contact tracing, that may change that. I should also note in that ARPA funding, when we talk about expansion of respite, we're looking to stand up a longer term and ongoing respite center specific to children with complex needs. So not the same as the step down unit, but just in terms of being able to provide dedicated respite to children who need, where families need some extended time for whatever reason. So that we would be looking to use that federal funding for as well. So during the pandemic, parents were able to apply to work with their child and get paid. Some states allow this regularly. Would CT consider this? So I'll have to double check my notes and we'll clarify when we take these questions and put them in writing. We pay family member. We are allowed to be a paid family member now. I don't know if it's inclusive of parents, but I think it can be. However, you can't be the guardian and you can't be the employer of record. That is what we waived during the pandemic for some families, I believe. I could be wrong on that, but I think it's a possibility now. What I can tell you is that there are two large debates going on federally over this concept. One comes that paying family members to take care of their loved ones is potentially ripe for fraud and abuse, and that's one school of thought that's being discussed and why the feds shouldn't go that way. The other school of thought is with the aging of our population in general, that we are becoming top heavy in my age category and beyond. Means that that we don't have enough facility-based care for all the seniors and everybody else who might need it. And so outside of the disability community, the feds are examining whether they're better off paying family members to care for loved ones. And so there is some supportive conversation leading towards paid family caregivers. So I think we need to watch that closely. I don't know if Krista was on the line for tonight, but I know that she's been having some conversation. Krista is works in our Medicaid work. So we'll have to get back to you on more of that. Is CT considering that? We need to do it with guardrails and safety around the fraud and abuse issues, and that we can get around this language around paying yourself as the employer of record or guardian. And so we'd have to work through what those things are. But I think it's, if not immediate, it's in the future for us, certainly. Is there a plan for additional funding to return individuals to adult programs? I'm assuming day programs. Many do not have transportation or budget for transportation now that transportation is limited due to COVID. Well, if you'd asked me 10 days ago, I would tell you that as of today, we would see a lot of those restrictions disappear. The minor outbreak we had in a public setting, 3 people exposed, no one sick, no one hospitalized, but in this Delta variant makes that a little scarier. But we are working with DPH to reduce reduce the burden, especially around the transportation issue. So we will provide a more comprehensive answer to that. I think some people are engaged in trying to figure out how that happened. I don't think additional funding is necessarily the answer. It's the space, I go back to, when you have a lot of people in one building, do you have enough space for them to all be 6 feet apart, still have adequate supervision, and how many people can you fit in there? But there's also the workforce shortage. So prior to the wage package and the wage implementation on July 1, we had providers across the state telling us that they were holding job fairs. They'd have job fairs and no one would show up. They'd have job fairs and a lot of people would show up. And in fact, one provider indicated to me they had about 400 people show up to job fairs. Not very many filled out applications, and only 2 were actually qualified to provide the work. So they were hoping, in order to open their day programs, that they could pick up as many as 50 or 60 staff from those job fairs, and they netted 2. However, I can tell you that today, I heard from during a meeting with regional directors, some of whom were maybe listening in tonight, that we had providers say it's really started, the word has gotten out about the wage package, that you can make $16.50 an hour walking in the door, and they're starting to see more applicants come through. But we'll evaluate that. We would like to be able to see everyone get back to normal, whatever normal is going to be. So we'll include that in the questions asked and provide some answers to that as well. Supported decision making. Will supported decision making be available soon for individuals with intellectual disability instead of conservator or guardianship? I got a brief update from Rod O'Connor, who's been working with a group of people who are very interested in supported decision making. I'm not going to go into a full explanation on the call tonight about what that is if you're not familiar with it, but we'll include a link to the current work going on it, both locally and nationally. So as a guy who's grown up as the person-centered guy I keep branding myself as, I would love nothing more than to see supported decision-making be available. I've worked in other states where conservatorship and guardianship is less readily available to families, and in fact discouraged, because there's some upsides and some downsides to both of those things. I'm not saying it's a bad thing. I'm just saying that conservatorship and guardianship isn't necessarily for everybody. Likewise, supported decision-making won't be available to everybody or be liked by everybody, but it should certainly be part of the menu of options we have for how people make decisions and how decisions can be made for them in times of need without surrendering guardianship or being conserved. Does the move, so number 5 on the question list, and I have 7 just so you can gauge your time you're spending with me. Does the move to more value-based decisions, lesser restrictive environments, and using savings to serve more people mean that our larger institutions will be closing? I left Southbury out intentionally because it's a lightning rod for conversation. The answer is, at some point in our future, Southbury won't exist. Whether there's an intentionality in shutting it down, I'm not certain. There's a settled agreement, a messier settlement agreement governs how we handle the dispensation there at Southbury Training School. And it's not that long ago that we closed 2 institutions. We closed El Agrasso Center and the Meriden Regional Center. So we've gone from 5 to 3 in the short time, a relatively short time I've been at central office. Right now, you need to understand that those public settings, those public programs have been the backstop very often that has worked with us to support very hard to support people that the private provider community wasn't able to in a timely fashion. And that's the backstop for me from having to send people out of state when we have no other options. So there will come a time where we are continuing to downsize those and trying to use those more for clinically acute and transitional services. But I can tell you that, you often hear, Virginia made a big proclamation about closing all their institutions. And then if you read the fine print, it's not really all their institutions. Other states have done the same. They still have 80 and 90 public beds that they use for the same reasons we will be. So I'm pretty transparent. I don't like to mislead you. I don't think we'll rely on them as heavily going forward. I think they will continue to shrink in terms of their census. but I don't see any real opportunity or any significant savings. You know, we talked about percentages of things earlier. More than 90% of the services provided in the state, more than 90% are provided in the private sector. Public only represents roughly 5% of the supports were provided, and not a very disproportionate share of costs given the complexity of those they serve. So while there's some savings potentially in the hour for hour difference between what public staff make and what private staff make, that difference got a lot smaller when the secretary and the governor agreed to a $16.50 minimum wage. And the flexibility, you know, I can make public staff do things we can't make private providers do. And until we have the rest of those transitional supports stood up, transition to private services, I see public sticking around for some time, including some of those larger settings. Is there a way for parents to know the vaccination rates of staff and individuals at day programs or group homes, et cetera? No, I don't actually get to know that either. Or if I could, and it wasn't a violation of people's individual rights, I would share that with them. Private providers, legal teams may give them different advice about what they can share and what they cannot share. They may be able to make decisions that the state can't make. As you've heard, lots of schools, public place institutions of learning are requiring vaccination and demanding evidence of that. We're not in the position as the state to do that for our public staff. I believe that some private providers have, others have not, and I don't know what they can tell you about who's vaccinated and who's not without breaking the confidentiality currently. One thing you should know is any consideration the state would give to mandating or providing evidence would be incumbent upon the current immunizations being declassified as emergency use authorization and moved to full use authorization, fully blessed by the CDC. And we'll wait for more information on that. And the last question I have for you that I'll be able to answer tonight. This does not necessarily indicate all the questions that were received. We just picked a few, triaged a few to try and provide some give and take for some of you tonight. How do you get information on the step-down unit? There is nothing on the DDS website. So the referrals for the step-down unit do not come from families. The referrals for the step-down unit need to come through the regions, and regional directors to our public staff. That was intentional because for a variety of reasons. But if you have someone who's stuck in a hospital or headed to a hospital because they've suddenly decompensated and need short-term acute care for stabilization, you can talk to your case managers and the regional staff, and they can help you determine whether or not that might be a service that your loved one is eligible for. So with that, folks, for tonight, that is all I have to share today. I could talk for hours. I love what I do, and I look forward to more of these conversations. If you can email me directly, many of you know I'll respond on my own, but please consider using the link. Include in your message if you want a direct response as opposed to it being just a frequently asked question. Provide your contact information. The email will detail that. If you wish it to be anonymous, you can just use the forms as indicated. We won't know where it came from unless you tell us where it came from. So feel free to use the forms anonymously if you so choose. I thank you for sticking around for a little over an hour and 15 minutes with me, and I look forward to seeing you again. Thank you, everybody, and have a good night.